Good morning, everyone. My sincere thanks to Director General Dr. Ashok Joshi and Dean Dr. Sunita Joshi for their kind invitation to me to be the keynote speaker at this wonderful conference. My sincere apologies that I'm not able to join in person, but I'm hoping that the internet highway has not taken a vacation day today and that you are able to play my pre-recorded keynote address this morning. Before we talk about data analytics and its implications on healthcare, let's look at a scenario that we often find ourselves in. We all have an Uncle John, and let's say that Uncle John is 65 years old and he has been diagnosed with diabetes. His blood sugars have not been in good control, and he's trying to find a physician, a primary care physician, who could better help him with his blood sugars. Now, you are working as a hospital administrator. Uncle John visits the clinics and the hospitals in the system where you are working. Uncle John narrowed his choices to two good doctors, and these two doctors are Tendulkar and Dhoni. Let's say that your favorite cricket stars retired and they both took up medicine. So they are working as physicians, and you would like to help Uncle John make a decision between Tendulkar and Dhoni. For those of you who are familiar with US sports, maybe you could replace Tendulkar and Dhoni with Rodgers and Brady. So how would you go about deciding whether Uncle John should see Tendulkar or Dhoni? Before we help Uncle John, let's look at the current situation. Let's try to understand why we are in this position where many patients like Uncle John are looking to receive quality care, but they are unable to. If you look at the landscape in the US, the United States government spends about $1.1 trillion on healthcare. Out of this, about $580 billion, billion with a B, is spent on the Medicare insurance program. Most of the healthcare reimbursement models thus far have rewarded the volume of care. That means if you are a physician and the more patients you see, the more reimbursement you get. When you look at the quality of care, US lags compared to many other countries in a few key categories. So many key stakeholders, including the patients and the legislators, are asking the key question: if we are spending $1.1 trillion every year on healthcare, where are the results? In an effort to improve the quality of care, the United States has launched quite a few initiatives, and one of them in the last few years is known as the Accountable Care Organizations. Basically, accountable care organizations, they promote the quality of care rather than the volume of care. Hospital systems can become accountable care organizations, and their reimbursement is slightly different. In addition to some of the volume of care reimbursement, they also tend to get incentives if they show that they're meeting certain metrics that show that patients are receiving quality of care. The Centers for Medicare and Medicaid Services, they provide a loose definition for ACOs, and I highlighted some of the key points here. Basically, they need to promote quality of care. They need to make sure that they are providing right care at the right time. So how are these ACOs measured? There are, for the calendar year 2018, there are about 31 different measures, and these different measures are categorized into 4 key domains. And one of them is how is the experience of the patient. The other measures include how well the ACO is promoting patient safety and how well the ACO is taking care of the chronic patients, patients with diabetes, hypertension, depression, heart disease, and so on and so forth. Last but not least, there are 8 measures on preventive health. If you look at the patient caregiver experience, a few of the examples I'm showing on this slide, some of these include, are the patients getting timely appointments? Are the patients able to get better communication from their physicians? Are they able to get access to the specialists if they need to see a cardiologist, for example? How fast are they able to get an appointment with the cardiologist? And how are these measured? This data comes from a survey conducted on the patients. The patients get to rate their physicians, and these survey results provide the data for these quality measures. When it comes to patient care coordination and patient safety, these are the measures. Most of these measures, or a number of these measures, do focus on unplanned admissions for patients with chronic diseases such as diabetes, heart failure, or multiple chronic conditions. For the preventive care, the ACO is required to provide, for example, influenza vaccines. Similarly, pneumonia vaccines for the elderly patients who are at risk. For the clinical care for at-risk population, there are a few specific measures. How well is the ACO controlling the blood sugar levels? The hemoglobin A1C is used to measure whether the patients are having poor control or better control of blood sugars. Similarly, are the diabetic patients receiving annual eye exams? Is the ACO controlling the high blood pressures of hypertensive patients? Now, all these measures require the data in order to be computed and reported back to the Centers for Medicare and Medicaid Services. So let's look at how we would compute one specific measure. The measure that we are going to focus on is ACO 27. This is where we need to find out what is the percentage of patients that have poor control of their hemoglobin A1C levels. So to compute the ACO 27 quality metric, we use a very simple formula. The formula is number of patients with HbA1c greater than 9% for that calendar year by the total number of diabetic patients. This might look very simple, but the fact is that, as they say, the devil is in the details. There are a few things that we need to consider. When we look at the numerator, for example, if a patient's test result is missing or if it was not conducted, that counts against the ACO. For the denominator, we only should be looking at the patients in the age group 18 to 75 with type 1 or type 2 diabetes. For the denominator, once again, when we come to which patients are included, they could have two face-to-face encounters, two or more face-to-face encounters in a clinical setting, or one face-to-face encounter in acute inpatient or emergency room type of setting. Once again, coming back to the denominator, we should exclude patients that have, for example, gestational diabetes. If a pregnant lady develops gestational diabetes, that condition is considered temporary, and she should not be included in the denominator. As you can see, all these measures require a tremendous amount of data. This figure represents a high-level schematic of the infrastructure used for healthcare data analytics. Healthcare data can come from a variety of sources. For example, smart meters that track blood glucose levels of patients can transmit these readings, and they are stored in one database, and that is labeled as sensor data in this diagram. Medical records of patients in the US are typically stored in electronic health records, or EHRs. The EHR data is a separate data source. Data from patient surveys is in yet another database. Similarly, the genome data and the public health records data can be used when needed for different applications. So, a data warehouse is a big database. Think of it as a big database that uses all this infrastructure and brings in all kinds of data on patients. And the data warehouse can include different records and different fields, different attributes from all these databases that are shown on the left-hand side. But the fact is that not every application needs the whole data warehouse. For example, a research division that is studying the effectiveness of specific medications in patients, it could use a smaller data mart. So whatever data we need for different applications, they are placed in these smaller data marts that are shown in the middle of this diagram. Moving to the right-hand side of the diagram, several platforms and programs can be used to conduct analysis on data and arrive at meaningful conclusions. Some of these programs are SAS, SPSS, and R. One advantage of R for statistical analysis is that it is open source and freely available. We can also use software packages such as Tableau or Power BI for data visualization. To extract data from databases, structured query language is a common language that works across multiple database formats. For example, a database query to extract patient lab test results data is shown in this schematic, in these schematics. Now let's come back to Uncle John's dilemma. I know we took a detour of what quality means in healthcare and what kind of infrastructure do we use for data analytics. But now coming back to Tendulkar or Dhoni as the physicians, as a primary care physician for Uncle John, how do we go about it? There are a few key things we need to do. We need to extract relevant data from the database. we have to compare between Tendulkar and Dhoni how their patients are doing in terms of blood glucose readings. So for that, the data is available in some of these databases, and so we have to get that data from those databases. We also need to formulate a hypothesis, a statistical hypothesis that the means of HbA1c levels for the patients of Tendulkar and Dhoni are the same, or statistically, there are no statistically significant differences between those two means. And then we need to utilize a package like R to conduct a statistical test. In this case, since there are only two physicians that we are comparing, we would use the t-test to conduct this. And then we have to interpret the statistical test results and draw conclusions on whether Tendulkar and Dhoni have statistically significant differences in terms of their patient blood sugar levels. So let's look at the infrastructure schematic and apply that to this scenario, helping Uncle John. So the data for some of this might come from electronic health records data, or the patient survey data, or the sensor data. Why these three? Any lab test results, I'm including that, considering that as part of the EHR, or the electronic health records data. The sensor data, if the patients are uploading their blood glucose levels through smart meters, that might come through the sensor data. The patient survey data, you don't want to send Uncle John to a grumpy physician, and that's where the patient survey data can play a significant role. Then that data could be pulled into a data warehouse and to a data mart. It's probably already available in a data mart by the time you go to the analysis phase. And then you would use something like R to connect to these data sources and conduct your statistical analysis. The terminology for extracting the data from the database, transforming the data, and loading the data into a data warehouse and a data mart, that is often referred to as ETL, extract, transform, load. And once we are conducting statistical analysis, we are utilizing that data, analyzing and interpreting on the right hand. Now let's take a slightly different example for data analytics. You are working as a sales manager for a large pharmaceutical company. We have Abbott Labs and AbbVie near University of Wisconsin Parkside. Let's say you are working as a sales manager for them. Your company sells medicines and medical equipment such as coronary stents to hospital systems. Your goal is to predict the total number of medical equipment your company will sell in the coming years. So for example, you could consider one of these products such as coronary stents and see how many of them you would be selling in future years. One possible way to predict the total number of medical equipment is to use a growth curve. If you assume that the growth is slow initially, then growth takes off as the product becomes more and more popular, then the growth tapers off. If you take this model, you can use a growth curve such as the S curve and the Pearl curve. I know all of you are waiting eagerly for the details behind these curves, how the mathematical equations work, but because of lack of time, let's skip this part and move to the next example. Now, in this third example, let's assume that you are working as an auditor at the Centers for Medicare and Medicare services, Medicare and Medicaid services. You are looking at the claims submitted by 4 different hospitals in the same urban area. Let's say the urban area is Milwaukee, Wisconsin. And these claims that are submitted by these 4 different hospitals are for treating heart failure and shock without complication or comorbidity, or major complication or comorbidity. For those of you familiar with the US healthcare reimbursement system, all these claims are based on an MSDRG code. The MSDRG stands for Medicare Severity Diagnosis Related Groups. In this case, for treating this condition, the MSDRG code is 293. For some reason, the claims submitted by these 4 different hospitals, you are suspecting as an auditor that these are vastly different. So you want to find out whether there are any statistically significant differences among the claims for these hospitals that are treating really similar patients in the same geographical area. So how do you go about it? You look at the claims data, because that's probably the only data or the main source of data that is available at the CMS. And you would pull this data into a data mart. Once again, you can utilize any of the statistical packages, including R, to analyze this data and determine whether there are statistically significant differences among these 4 hospitals for MSDRG 293. So in conclusion, healthcare quality in the United States seems to be the driving force, and this is picking up momentum. This decade is going to see more and more emphasis placed on healthcare quality. The other thing that is happening is that the big data revolution in healthcare is real and is here. Different varieties of data, different sources of data are being pulled together, and people are trying to draw meaningful conclusions of this wide variety of data sources. So if you are a student and you are trying to progress in your career, in addition to the power skills such as the communication skills, the interpersonal skills, and making sure where you fit in the organization, how you can progress in the organization, in addition to these power skills, you would like to gather some of these technical skills such as the databases, the structured query language, the spreadsheets. How do you use statistical packages such as R or SPSS? And you need to have a very good understanding of the statistical analysis skills in order to work in data analytics. Ultimately, you want to use these skills to make better decisions, data-informed decisions that will help your organization. I would like to thank you for your time this morning. And if there are any questions or comments, I would be happy to take them now. But before I open it up for questions, I just want to mention that the partnership between the University of Wisconsin-Parkside and IndSearch is very, very special. Our partnership produced a number of wonderful graduates who are productive and responsible citizens of this world. We are proud of this partnership and proud of the students who have roots on both of our campuses. Thank you.